Hey there, health enthusiasts. Welcome back to our channel. Today, we're diving into a topic called otitis media. Now, before we get started, make sure to hit that subscribe button and ring the notification bell so you never miss out on our valuable content. Let's jump right in. Acute otitis media is defined by convention as the first 3 weeks of a process in which the middle ear shows the signs and symptoms of acute inflammation. Otitis media with effusion is defined as the presence of fluid in the middle ear with accompanying conductive hearing loss and without concomitant symptoms or signs of acuity. Otitis media with effusion is classified as subacute when it persists from 3 weeks to 3 months after the onset of acute otitis media and is classified as chronic thereafter. Chronic suppurative otitis media is a chronic inflammation of the middle ear that persists for at least 6 weeks and is associated with otorrhea. Acute otitis media is a common problem in early childhood necessitating medical therapy. 75% of children have at least one episode by school age. Peak age prevalence is 6 to 18 months. Most occur in children younger than 6 years. The tympanic membrane can be divided into quadrants, with an imaginary line drawn vertically along the long process of the malleus and extending to the inferior annulus, along with a horizontal line at the umbo. Behind the posterior superior section lies the incus and stapes, structures that might be injured inadvertently by incision in this area. The area above the pars tensa, the pars flaccida, also should be avoided. Obstruction of the eustachian tube appears to be the most important preceding event associated with acute otitis media. Most episodes are triggered by an upper respiratory tract infection involving the nasopharynx. Also, allergic and other inflammatory conditions involving the eustachian tube may create a similar outcome. Inflammation in the nasopharynx alters the pressure within the middle ear. Stasis also permits pathogenic bacteria to colonize the normally sterile middle ear space through direct extension from the nasopharynx by reflex, aspiration, or active insufflation. These processes lead to otitis media. Otitis-prone children include patulous or hypotonic eustachian tube and children with neuromuscular disorders. Talking about the immune system, immunoglobulin G2 and immunoglobulin G4 deficiencies are involved in otitis media like in Down syndrome. Causes of acute otitis media are often multifactorial. Common etiological agents include RSV, S. pneumoniae, most common etiologic agent in children of all age groups, H. influenza, Moraxella catarrhalis, and Streptococcus pyogenes. In the perinatal period, the Escherichia coli, Enterococcus species, and group B Streptococci are the etiologic agents most commonly responsible. Risk factors include exposure to cigarette smoke from household contacts, prematurity and low birth weight, young age, early onset, family history, race, Native American, Inuit, Australian Aborigine, altered immunity, craniofacial abnormalities, neuromuscular disease, allergy, daycare, crowded living conditions, low socioeconomic status, tobacco and pollutant exposure, use of pacifier, prone sleeping position, fall or winter season, absence of breastfeeding, prolonged bottle use. When assessing the history of the illness, you need to ask about any recent symptoms of upper respiratory infection. Neonate present as irritability or feeding difficulties. Older children begin to demonstrate a consistent presence of fever and otalgia or ear tugging. In older children and adults, hearing loss becomes a constant feature of acute otitis media and otitis media with effusion. Other features: otorrhea, loss of appetite, vomiting, lethargy. Check for cochlear implants and immunocompromised status. Pneumatic otoscopy is performed to assess tympanic membrane's color, position, mobility, and perforation. All images shown below are taken from RCH Guidelines. The first picture shows a normal tympanic membrane. It is translucent. The handle of the malleus is vertical. No erythema. The second picture is an injected tympanic membrane. It is pink/red. Often seen with fever, eustachian tube obstruction, or viral upper respiratory infection. It is transparent, there is no middle ear effusion. The handle of the malleus is well seen and is more horizontal. The third picture shows bulging and red tympanic membrane in acute otitis media. There is a loss of the membrane landmarks, especially the handle of the malleus. The membrane is opaque, may be red from inflammation or white from pus in the middle ear. The first picture here is otitis media with effusion. The membrane is retracted with prominence of the handle of the malleus, which is also drawn in or more horizontally. It may be bulging or have an air fluid level behind it. Yellow or amber appearance is consistent with fluid. Light reflex on otoscopic examination. The second picture shows a perforated tympanic membrane with otorrhea. The last picture shows otitis externa. The ear is tender to examine. The skin of the external ear canal is swollen and there can be thin pus. Other methods to examine ear include tympanometry, acoustic reflectometry. Acute mastoiditis. Acute mastoiditis, although rare, is the most common suppurative complication of acute otitis media and may be associated with intracranial complications. Prompt treatment with appropriate intravenous antibiotics and ENT consultation for mastoidectomy. Otitis media with effusion. Cholesteatoma. Labyrinthitis. Facial nerve paralysis. Meningitis. Epidural abscess. Lateral sinus thrombophlebitis. There is no role for routine diagnostic investigation for acute otitis media. Diagnostic imaging such as CT and MRI is usually only required in children with suspected intracranial complications. Full sepsis workup in infants younger than 12 weeks who present with fever and associated acute otitis media. In acute otitis media, most cases resolve spontaneously and antibiotics are not recommended. If needed, medical management includes amoxicillin as the first line. Allergic to this can use cephalosporins, trimethoprim sulfamethoxazole, and macrolides. For otitis media with effusion, antibiotics and ENT referral are not routinely required, as the majority of cases occur after an episode of acute otitis media and resolve spontaneously with no long-term effects on language, literacy, or cognitive development. Medical treatment includes antimicrobials, antihistamine decongestants, intranasal and systemic steroids, nonsteroidal anti-inflammatory drugs, mucolytics, and aggressive management of allergic symptoms. RCH Guidelines states that persistent effusion beyond 3 months should trigger a hearing assessment and ENT involvement/referral. Surgical care for otitis media, tympanocentesis, myringotomy, and tympanostomy tubes. Some studies show adenoidectomy and tonsillectomy. The use of pneumococcal and influenza vaccine is beneficial. The flow chart from RCH Guidelines shows the management of acute otitis media. Most cases resolve spontaneously and antibiotics are not recommended. Treat pain with adequate and regular simple analgesia. If unwell, not improving in 48 hours, or have red flag signs, need antibiotics. As an adjunct, short-term use of topical analgesia, e.g. 2% lignocaine, 1 to 2 drops applied to an intact tympanic membrane, may be effective for severe acute ear pain. Decongestants, antihistamines, and corticosteroids are not effective in acute otitis media. The below information has been gathered from RACGP on the management guidelines for Aboriginal and Torres Strait Islander children. The link is given in the description below. In episodic bilateral or unilateral otitis media with effusion, review monthly. Persistent bilateral or unilateral otitis media with effusion, 3 months, review monthly. Antibiotics if bilateral for 3 months and risk factors for chronic suppurative otitis media. Refer for ENT assessment if otitis media, if effusion persistent for 3 months or hearing loss of greater than 20 dB in the better ear or severe retraction of the tympanic membrane. Nasal balloon inflation therapy has shown benefits. Acute otitis media without perforation, if not high risk, observe and treat with oral analgesics. High risk, treat with amoxicillin. Acute otitis media with perforation, give amoxicillin. If no improvement, increase the dose or give azithromycin. Recurrent acute otitis media, prophylactic antibiotics are not routinely recommended, only for children less than 2 years old with recurrent acute otitis media. Probiotics, Lactobacillus rhamnosus GG, may reduce the incidence. ENT assessment when no improvement despite a trial of antibiotic prophylaxis. Chronic suppurative otitis media. Clean pus from the ear canal with dry mopping, syringing, or suction. Instill ciprofloxacin ear drops and give amoxicillin. Refer for ENT. Tympanostomy tubotorrhea, clean pus from the ear canal with tissue spears or syringing at least twice daily. Instill ciprofloxacin ear drops. Dry perforation, record size, position and refer to ENT. Thank you for joining me today to explore the world of otitis media. If you found this video helpful or informative, don't forget to give it a thumbs up and subscribe for more engaging content on various medical topics. Feel free to share your thoughts, questions, or personal experiences in the comments section below. Until next time, take care, stay curious, and be well.